Right. Good morning, everybody. Now, Mr. Gale, when you're ready.
Thank you, my Lord. My Lord, today there are two witnesses, both who are here in person. They represent organizations who, at present and during the pandemic, supported and continue to support, in particular, disabled people, organized and marginalized groups, and also unpaid carers during the pandemic. The first witness is Sara Redmond of the Health and Social Care Alliance Scotland, which is referred to simply as the Alliance. She speaks to a witness statement. The reference to that is SCI WT 0584 and then 501. The second witness is Tressa Burke, that's TRESSA Burke. She speaks on behalf of the Glasgow Disability Alliance, which I think we'll refer to as the GDA. And she also speaks to a witness statement, which is SCIWT 000862. So, Miss Redmond, please.
Very good. Thank you. Good morning, Miss Redmond. Please be seated.
Thank you.
Right. You ready? Mr. Gill.
Ms. Redmond, good morning.
Good morning.
You provided the inquiry with a statement, and that statement is on behalf of the Health and Social Care Alliance Scotland, which I think we're going to call the Alliance, and your Chief Officer of Development for that organisation. Is that right?
That's correct.
You don't need to tell us your date of birth, but could you just tell us your age, please?
I am 40.
Thank you. And the inquiry knows the address of the Alliance for communication purposes. Your organisation has engaged with the inquiry. We have had meetings with you. You provided a considerable amount of information to the inquiry, and for those with looking at your statement, if one goes to the end of your statement, there are a considerable number of references, all of which have links to documents that you have provided to the inquiry, and I should say that the inquiry is studying those documents and will be taking all those documents into account, albeit you do refer to them briefly as you go through your statement.
That's correct.
Now, if I can just take you to your statement. You're responsible, as you say in paragraph 1, for leading and continuing to shape the vision of the organization, and you're responsible for developing the strategic direction of the organization and also overseeing its portfolio of programs. And you then say, central to this is ensuring a strong voice for disabled people, people living with long-term conditions, and unpaid carers, and the opportunity to influence change based on their lived experience. Now, you are here really to tell us about the experience that your organization had and the people who are associated with your organization had during the pandemic. And you are also here to tell us certain of the lessons which you see, based on that experience, suggests that we might, as an inquiry, wish to learn and to make possible recommendations in relation to. But first of all, can I just understand a little terminology? And maybe, and I'm sure it is very obvious to you, but you mention on several occasions, and in particular in paragraphs 2 and 3, the third sector. Can you explain to us what the third sector is, please?
Yes, of course. So the third sector is a term that refers to charities, voluntary organisations, social enterprises, community groups. The groups and the organisations that would be working not for profit but for a social purpose, and who would be largely, who would reinvest any income or any funding that they generate back into the cause of that business.
And we'll come to your funding in a little, but in paragraph 3 you say that the Alliance are the national third sector intermediary for health and social care, bringing together a diverse range of people and organisations who share our vision, which is, as you say, that Scotland is somewhere where everyone has a strong voice and enjoys their right to live well with dignity and respect. Right, third sector intermediary. Intermediary with whom?
So we are both a membership organisation and a connecting organisation. We operate almost as a bridge between, particularly between Scottish Government and decision makers and those members that we represent. You know, it's a terminology to reflect that we're there to represent the interests of our members.
And in paragraph 4, I think you expand on that where you say we are a strategic partner with the Scottish Government, close working relationships with many NHS boards, academic institutions, key organisations, spanning health, social care, housing and digital technology. And I think these are all aspects that came into play very acutely during the pandemic. Could you just go to paragraph 5, and I am going to ask you, if you don't mind, to read certain parts of your statement. If at paragraph 5, could you just read on from there, please?
Yeah, so our purpose is to improve the well-being of people and communities across Scotland. We bring together the expertise of people with lived experience, the third sector, and organisations across health and social care, and we inform policy, practice and service delivery. Together our voice is stronger, and we use that collective voice to make meaningful change at the local and national level.
Just carry on, please.
Okay. So the Alliance has a strong and diverse membership of over 3,400 organisations and individuals. Our broad range of programmes and activities deliver support, research and policy development, digital innovation and knowledge sharing. We manage funding and spotlight innovative projects, and working with our members and partners, we work to ensure lived experience and third sector expertise is listened to and acted upon by informing national policy and campaigns and putting people at the centre of designing support and services.
And then you set out your aims. Could you just read those, please?
Certainly. So our aims are to ensure that disabled people, people with long-term conditions and unpaid carers, expertise and rights drive policy and sit at the heart of design, delivery and improvement of support and services. We aim to support transformational change that works with individuals and community assets, helping people to live well, supporting human rights, self-management, co-production and independent living. And we champion and support the third sector as a vital strategic and delivery partner and foster cross-sector understanding and partnership.
And in paragraph 8, you refer to an inquiry. I take it this is this inquiry.
That's correct.
And can you explain why you felt an inquiry, what should take place?
So based on the work that we delivered over the years spanning the pandemic. The insights that we gathered, our responses to public information, to guidance, to policy developments, and quite extensive engagement with people about their experiences of accessing health and social care over that period, and the impact that period has had on people's health and well-being. We felt strongly that there was a need to identify and learn lessons from this experience. We were concerned that, despite a commitment to human rights principles and standards, that decision-making did not reflect, from some of the experiences shared with us, human rights standards and principles, that people's rights who were most at risk were not really being considered when decisions were being taken. Information was not easily understood, was not easily accessed for many people. And I think we felt that there was also opportunity for us. Health and social care is not necessarily renowned for being particularly quick to transform itself, and yet there was, really quite significant examples where, change took place at pace and nationally, and we also thought there was an opportunity to learn the lessons from good practice that had happened, so that we could apply those.
Yeah. And I think you make the point in paragraph 8 that, and this is something that we've heard, and I think we're going to continue to hear, that during the pandemic there were examples of good practice that came about at pace.
Absolutely.
But there are also examples of bad practice. And we obviously need to recognise both. Yeah. In paragraph 9, you go on to indicate how the Alliance engaged with various committees of the Scottish Parliament, and I think we can probably just take that as read for present purposes. And at paragraph 10, you tell us what the Alliance did in terms of what is called the People at the Centre Engagement Programme. Perhaps you just read paragraph 10 so that we understand that, please.
Certainly. So in 2020, the Alliance undertook the People at the Centre Engagement Programme. This was a programme of engagement looking at short and longer term reform of the health and social care system. So it was an engagement programme to learn lessons from people's experiences following the COVID-19 pandemic outbreak in Scotland. The programme captured the lived health and wellbeing experience of the COVID-19 pandemic. Over 1,000 people across each of Scotland's 32 local authority areas were engaged with, and their experiences captured, and those were collated and analysed, and the prominent themes were drawn out in a final report. And
again, you provided us with that report. It's referenced in your statement, and the link is provided. Now, going on, you say we continue to hear and gather information or evidence on the lasting impact from our members. Perhaps again, could you just read that so we have that in context?
Yeah, absolutely. So we continue to hear and gather evidence on the lasting impact of COVID-19 from our members, including for those living with long COVID. In 2022, we published commissioned research on accessing social support for long COVID. The research aimed to build understanding of the life circumstances of people with long COVID in Scotland, as well as their experiences of accessing social support. We also commissioned research into the lived experience of COVID-19 of marginalised communities as a member of the Inclusion Health Partnership and the CLEAR Partnership, which is the Community Lived Experience Action Research Partnership. And we've also published research exploring disabled children and young people's and their carers' experiences of accessing healthcare services and support during the pandemic.
Can I just ask you about long COVID? You may be aware that the inquiry does have a remit to consider long COVID in particular circumstances, and we've issued guidance and advice on that. Can you just indicate why it was that in 2022 you commissioned research in accessing social support for long COVID. Can you just explain why you did that?
So during the 2020 engagement programme, we had a particular focus group and gathered information from people living with long COVID at the time. In the subsequent years, we were continuing to hear from people living with long COVID through a range of different forums and groups that we were members of, that the experiences that they'd had then had continued. So in terms of the support they were receiving, the challenges they were finding in terms of the awareness of the condition, you know, really the range of symptoms and those experiences being believed and understood. And also, despite some of the policy developments around long COVID service across Scotland, people weren't necessarily describing that they were then experiencing that support as available in their local areas. And so we commissioned this research really to understand in a bit more detail what people's experiences were, you know, further on, so a couple of years since the onset of the pandemic. And
can you perhaps just very briefly explain what the outcome of that research was?
Yeah, I mean, I think the things that really stood out from that research was that people were very much, I think, shocked by the experience they had of being diagnosed with a long-term condition, and the challenges that they'd encountered with having that experience believed by the healthcare system. They raised concerns about just you know, battling to receive a diagnosis, that the range of symptoms that they were experiencing not really being accepted as part of the condition. They talked about the significant impact that it was having on their daily life. Many people having to leave work, having to rely on friends and family for support with the caring responsibilities that they had in life, that they were having to spend a huge amount of time researching support and treatment options, some describing having to look for private support and treatment. Some did describe support that they were receiving from the health service and good support from GPs and others. They typically tended to refer to themselves as being lucky for having that experience. And when they were discussing wider support, they spoke at length about the difficulties they'd had navigating the social security system, and none that we that were involved in the research that I can recall had any experience of accessing social care support. It had not been a route that they'd found accessible for themselves.
One of the things I think we will hear more about, and I think you've hinted at, is that there was, so far as long COVID is concerned, at various stages, some scepticism about the condition. Yes. And that seemed to permeate both the medical profession and the wider public.
Yes.
And I think you go on to deal with this later in your statement, but I think it's useful to just get that point across now. If we go back to your statement, you move from that group of impacted people to a reference to Engender. Now, you probably are aware that the inquiry is going to hear from a group of women's rights organisations tomorrow, and Engender is one of those organisations, so you can be assured that we are aware of that. But perhaps you could just indicate the partnership that you had with Engender and what that partnership brought to you.
Yes, so the Alliance worked in partnership with Engender to undertake research to look at the experiences of pregnancy and maternity services across Scotland during COVID-19. We worked to capture qualitative experiences from people who were accessing pregnancy and maternity services, and we were able to capture over 200 responses, and that covered the period from March 2020 to November 2022. The research aimed to get a better understanding of access related to pregnancy, fertility, maternity, abortion, miscarriage and postpartum care during COVID-19. And the report that we published from the analysis of those experiences drew together some of those key findings and made some recommendations for Scottish Government and relevant health bodies.
And I think you quote from one of the participants in the research. In fact, you just read that quote, please.
Certainly. It is essential that Scotland learns from people's experiences during the pandemic to improve maternity services and public health messaging. To do otherwise would be to fail and further compound the trauma of thousands of parents over the last few years.
Okay. You then go on to talk about, to a certain extent, one of the points we've already touched on, long COVID. Do you also go on to talk about discussions that you had with the Scottish Government on shielding vaccination and long COVID? And I think it is right that we recognise that you worked closely with the Scottish Government throughout the pandemic.
Yes.
And I think much of that work was very positive.
Yes, we were able to be involved in a range of groups, such as there was a communication group that involved health boards and others, ourselves, and there was another health and social care intermediary represented, and it was to both feed in information to Scottish Government about communication needs and public health messaging, but also to help with dissemination of that as well. Yeah. And involved in other similar groups as those reference around. We were involved in a evaluation advisory group when Public Health Scotland were looking at people's experiences of shielding and being on the high risk list and others similar.
Yeah. And I think you also tell us that you had direct liaison with Scottish ministers and directorates. This is at paragraph 15 of your statement. And your former chief executive was a member of the Mobilisation Recovery Group. Just tell us what that group was, please.
Mm-hmm. So this Mobilisation Recovery Group was set up by the then Cabinet Secretary for Health and Social Care. And even in 2020, there was a consideration about how will we look to, remobilising health and social care services. So at the time there was obviously a particular focus on care and treatment for people with COVID. But equally there was that view to how will we start to recover and remobilise health and social care services. So the group involved a range of stakeholders. There was, as you were saying, our former chief executive as a representative from the third sector. There was also representatives, I believe, from the independent sector, representing those working in care homes, and a range of health boards and members of Scottish Government directorates as well.
And within that group, what was the particular input that your organisation was intending to give or could give? Mm-hmm.
So our involvement was really to help ensure that the experiences of people, particularly people accessing health and social care, people living with long-term conditions, disabled people, unpaid carers, that there was that opportunity to feed in the experiences and the priorities of those individuals. And it was on the back of our membership of that group that we were then invited to undertake that wide engagement programme, the People at the Centre engagement programme. Okay.
I'm going to go slightly off script here. Ms. Redmond, it's my fault. You've mentioned on a number of occasions, and you continue to mention throughout your statement, the role of unpaid carers and your role in assisting and advising unpaid carers. Can you put in perhaps a relatively short paragraph what you feel was the role of unpaid carers during the pandemic and what impact there was on unpaid carers? Because we are mindful as an inquiry that there is a specific reference in our terms of reference to the role of unpaid carers.
Yes, I would say that the impact has been profound for unpaid carers. There's, I mean, I guess just to express, these are family members, these are loved ones of people that they also provide care for. There was almost a juxtaposition in one respect. Unpaid carers were and felt very much excluded from arrangements, from decision making, from decisions that were taken about people's care and support during that period of time. So they very much described experiences where their involvement was just sidelined. And yet, at the other side, they also were in a position where they were left very often to provide significant amounts of additional care to family members because of the disruption to other, support and care packages that people had access to. Many, described that they were, having to provide almost round the clock, 365 days, 24 hours, care and support to loved ones. And also at the same time, for example, people who were caring for disabled children, they were also having to provide education and schooling support. They were, despite the significant role they play, they were not able to accompany loved ones to healthcare appointments and to be there when information was being provided, when people were accessing healthcare and support. And we also heard experiences, as I'm sure you will hear more about as well, from people who were important part of a person's support when living in a care home environment, and all of a sudden being excluded from being able to be part of that care team during the period.
An expression that I've come across in the work that the inquiry has been doing, I've seen it on a number of occasions in a number of different sources, is that unpaid carers were the forgotten army during the pandemic, and indeed beyond the pandemic. Would you agree with that? Yes,
I think it's a phrase that we hear about and have heard, even before the pandemic, that there are more people providing unpaid care than there are paid carers within our social care system. They provide a huge amount of care and support, and in recognition of that, the Carer Scotland Act that was enacted in 2016 was there to outline and try and provide a description of the rights that people had as unpaid carers, the right to breaks, the right to be involved at significant points in a person's health and care journey, on discharge from hospital and similarly, and to be involved in decision making as a really critical part of the care and support that is important to people. I would also say from the other side of it, during our engagement, we asked what was important to people looking at the remobilisation of health and social care. And one of the strongest themes that came across was that people want family members to be involved in their care and support.
Yes. Right. Forgive me, I did go slightly off script for that, but I think it's useful to get that context. You, as I've said earlier, you've engaged very effectively, I may say, with the inquiry You've provided details of 110 relevant documents in response to a Rule 8 request that was sent to you, and again, express our thanks to you for doing that. The various, what you summarise at paragraph 19 of your statement are some of the points that are brought out. And I think, with respect, it would be useful if you just read that section so that it is public in this inquiry.
Yeah, absolutely. So these include responding to the Scottish Government, Social Work Scotland and the Scottish Commission for Learning Disabilities call for comment on the options for remobilising social care day services, including those for adults with learning disabilities and people with dementia. Responding to Scottish Government stakeholder questions on shielding next steps. A paper outlining the lived health and wellbeing experience of a broad range of people living in Scotland during the COVID-19 pandemic, as captured by the people at the Centre Engagement Programme, to inform the Scottish Government's Mobilisation Recovery Group. It gives insights into how people viewed health and social care services when restrictions were still in place, and shares their experiences and stories. A joint letter to the First Minister from the Alliance and 32 other signatories, calling on the Scottish Government to establish a third sector recovery and renewal fund for national third sector health and social care organisations. Advice for health and social care staff in Scotland during the COVID-19 pandemic. Co-produced inclusive guidance on accessibility and inclusive communication for people living with sensory loss in relation to the COVID-19 outbreak. Cross-sectoral guidance on issues including face coverings, social distancing and travel restrictions, co-produced in inclusive and accessible formats. Emails and papers relating to the Alliance's membership of the Scottish Government's Long COVID Task and Finish Group, which produced an implementation support note on managing the long-term effects of COVID-19. Requests from the Scottish Government to share information relating to COVID-19 on the Alliance's website and social media channels. Providing comments on a Scottish Government booklet with advice for people at highest risk. Communication with Public Health Scotland regarding the Alliance's involvement in setting up a panel of lived experience of shielding or supporting a shielding individual to inform Public Health Scotland's shielding evaluation report. Emails and papers relating to the Alliance's membership of Public Health Scotland's shielding advisory group. Emails and papers relating to the Alliance's membership of the Scottish Government's Vaccine Inclusive Steering Group. Agenda for a roundtable discussion on long COVID with the Cabinet Secretary for Health and Social Care. Providing comments on the Scottish Government's Coronavirus, Scotland Strategic Framework and shielding. Providing comments on a letter from the Scottish Government to those on the shielding list outlining protection levels and advice on what measures people should take to stay safe. Emails relating to the Alliance's membership of Public Health Scotland's Shielding Evaluation Advisory Group. Discussion with the Scottish Government regarding work on marketing materials to support public health against COVID-19 and wider respiratory viruses over the winter period. And email regarding the Scottish Government's campaign Clear Your Head and Alice, which is a local information system for Scotland, which the Alliance hosts as a supporting partner, and emails regarding the inclusion of Alice on the Ready Scotland website.
I think we can see from that you've been busy. Yes. Obviously, we have all these documents, and as I said, these documents are being analysed, have been analysed, and they will input into our consideration. Okay. Please be assured of that. You mentioned then the report Living with COVID-19, a report, and that followed a parliamentary event. I think we can probably read that and just take that as read. But I would like to just clarify what you say at paragraph 22, where you say, I think you talk about the media coverage of the pandemic. And you said, you say that it was portrayed as that only the vulnerable who were impacted, a damaging perception which fundamentally overlooked the rights of individuals at risk, their families and carers. Can you just expand on that a little, please?
Yes, certainly. The way in which the risks associated with COVID-19 were presented in the media and in public narrative led to almost a perception that for the majority of people there was not much of a risk to be concerned about with regards to COVID-19, and it was something which only the vulnerable had a reason to be concerned about. I think in addition to that, what we heard was that the way in which it was presented as something which, it was older people who were at risk of, also meant that many people, living with disabled children, people who were higher risk because they were immunocompromised, and for other reasons, their circumstances were overlooked and they weren't seen as visible in terms of the risk that this presented for them. I think there was a huge amount of concern as well that, if it's okay to I guess, expand upon this in respect of many people living with long-term conditions and disabled people feel almost systematically overlooked in society. Anyway, there was we heard from people during our engagement that the restrictions imposed upon everyone in society gave people an insight into what it is like for some people already without those restrictions, just because society is not accessible for them, and so there was almost a sense of a levelling down, if you know what I mean, that people were feeling like, well, this is, more people have, an opportunity to see what it's like when you are isolated because of how inaccessible society is. So the portrayal in the media that this was something that only those who are vulnerable need to be concerned about represented a narrative which many people already encounter in society, that their rights to live, the same quality of life as anyone else in society, is something which is undermined or overlooked. So they felt that the narrative that don't worry, most of you are okay, carry on about your business, actually really made it so that those who were at higher risk had to be extra careful, extra cautious in the choices they made. And I would add that is how people still feel, for those who feel really concerned and that they feel, very much still at risk from the impact that COVID presents to them, that now they are having to make and navigate those decisions really by themselves without a huge amount of support available.
Is that perhaps reflecting the perception that the worst is over? Yes. And I think you reflect that in paragraph 23, where you quote from one participant, and it'd be grateful if you'd just read that, please. Yeah, so this was during the event that members of our team held at the Carers Parliament last year, where one participant said, "We still have to be very cautious, for example, by wiping down packaging and mail. We've been advised by the GP to keep doing so. We feel that the rest of the world has moved on and we haven't. It feels like people think COVID-19 never happened. You get your vaccinations and boosters, but you're just left to get on with it." Thank you. In the next three paragraphs, you go on to talk about, if I can give it a general heading, communication. And I think this is a particular point you want to get across to the inquiry. And indeed, it's one of the points you make at the end of your statement, as a recommendation from you that the inquiry should be aware of. In paragraph 24, you say 1 in 4 respondents said that they simply not received any information, and 22% felt concerned that they were receiving unclear guidance about the right procedures in terms of shielding, self-isolating, and using PPE. The importance of getting out clear guidance is, I think, essential to your message. Is that right? How do you see that being taken forward in the event of there being a future pandemic? And I think this is really what you're saying in paragraph 25. Would you just read that?
Yes. So in the event of a future pandemic, the Alliance recommends further listening and co-production to ensure that people's experiences are embedded in the decisions made and the way in which messages are disseminated. The way in which messages are communicated must be clear, consistent and compassionate, and recognise the disproportionate impact of the COVID-19 pandemic and the impact that it has had. Messaging must be informed by human rights standards and principles, including non-discrimination, and consider those who are likely to be more affected by any future public health crisis and the measures taken.
Yes. You take that slightly further in paragraph 26, where you say that the Scottish Government must ensure, in the event of a future pandemic, that there is clear, accessible and timely communication to everybody in Scotland, including people with sensory loss and people with learning and intellectual disabilities and their families, carers, supporters from the outset. It includes ensuring materials are constantly available in accessible formats. I think one of the things that you make the point about is the need for that information to be in various languages.
Yes, yes.
And to be available to those with sensory impairments.
Yes. I think the other thing that we that is really important is that there are feedback loops. So we need to know that when information is provided, that it reaches those that it's seeking to reach. One of the things that we also found, and I think was quite successful during the work around the vaccinations, was that by working with voluntary and community groups and organisations, those where they have existing relationships, where there is trust in place. One of the things that was fed back around that is that, for some people there isn't necessarily the relationship and the trust with some of our institutions, and with the amount of misinformation that was also coming out, it was difficult for people to discern what to trust. So those organisations and groups where they have that trusting relationship, is a really effective way of information being cascaded. There was also the opportunity to be quite outreach focused and considering different mechanisms for getting information out to different parts of society, and I think that was one of the things that we were really concerned about, was that people felt what they were hearing nationally didn't chime with what they were experiencing locally. They were finding it very difficult to find the information that allowed them to understand what they could and couldn't do, how to stay safe, and also that they were finding that with regards to the circumstances that they faced in life, so having a health issue arise, a worsening of a symptom, some matter relating to their health or their social care needs arise, they weren't sure how to access those services and contacts in the health and social care system. They weren't able to find out what services were available, what weren't available, where they were in terms of waiting for care and treatment. So there was kind of a huge range of factors around the communication that people raised with us.
And I suppose one of the issues that you raise is that the information that was being put out had to be information that the recipient could trust.
Yes.
Because of some of the other information that was circulating at the time.
Yes.
You go on to talk about digital technology, if I can use it as a general heading. What's your view about that?
So I think this was, when we were talking right at the start about learning from innovation, increasing the access points through digital health and care tools and technology was something which, as an organisation, we were very aware the health and social care system had been seeking to take forward for, over a decade. And yet the pandemic really was a catalyst for accelerating the access points through digital. Through the engagement that we had, many people really welcomed that. They felt that the choice that they had around, how to access their GP, how to access other aspects of the health service, particularly if they were living in remote and rural areas, not having to travel to appointments, that was really welcome. On the other side of that, there was many people described feeling as though they were concerned that the blanket use of a digital first approach felt really challenging for them. There were some examples where people were receiving, physiotherapy, for example, through the virtual video conferencing technology platform, and they felt it didn't meet their needs. It wasn't particularly tailored. They weren't following, what was being provided. There was I remember a family member of a disabled child saying that, it was pretty much they were just left to deliver the physio to their child without the support that they usually would be getting. There were people who said that they were having lumps or symptoms checked out via the video conferencing technology, and they were concerned that was they were concerned about trusting the diagnosis at that point, because they didn't feel that if someone hadn't actually been able to see, to feel, to really assess whatever the symptom, whatever the scenario was for them, that they didn't trust that it was the same standard of care that they would have had face to face. There was.
I'm sorry.
Okay.
Well, I think you give a number of examples of that from paragraph 30 through to. Really to 35, various scenarios, people with sensory impairments, autistic people, pregnant women, and I think there's an interesting quote that you give in paragraph 33. Perhaps you just read that, please.
Yeah, absolutely. So this was in response to pregnancy and maternity services, with someone saying communication was extremely limited, poorly conveyed, and frequently appeared to be poorly understood by healthcare staff. I do not say that to blame the individuals in question, but to highlight inconsistencies with information sharing and staff support. And that refers to quite a lot of the examples that were shared with us. I would say people were extremely understanding of the pressures facing the health service and the social care support and services, and yet their experiences also needed to be understood and heard, and some of the decisions that were taken led to some really severe outcomes for people.
Yes. Now, in relation to pregnancy and maternity care, we will be hearing more about that, particularly tomorrow. But I think it's interesting what is said and again a quote from a source in paragraph 38. And it's a simple statement, but perhaps you could just read that. It's at the end of, I'm sorry, it's at paragraph 36, my apology.
Oh, yes.
Perhaps you just read that, and perhaps you explain how that statement is reflected in the rest of your evidence.
Our People at the Centre programme also heard from those who had experienced pregnancy and maternity services during COVID-19, who shared that the experience was anxiety-provoking and isolating due to the reduction in postpartum follow-up services and visitation allowances, with a quote shared, "Pregnant women were forgotten about and treated like second-class citizens with their rights taken away."
The other theme that you go on to in paragraph 37 is isolation. And you begin that by looking at it in the context of women's pregnancy and maternity care, but I think isolation was across the board.
Yes, yes.
Yeah. Perhaps you just read from 37 onwards, please.
Yes, so isolation was a key theme which emerged from our research, impacting all aspects of women's pregnancy and maternity care. Participants described undergoing distressing and traumatic experiences alone, including managed miscarriage, fertility procedures and abortion care. Additionally, lack of antenatal and postnatal support in the community contributed to poor mental health outcomes. The report calls for mitigations in a future public health crisis to prevent perinatal isolation and allow women to be accompanied when they are undergoing appointments, giving birth, experiencing miscarriage or baby loss. Learning from the experiences shared by members, it is clear there should be a blended approach to delivering services which is rooted in choice and flexibility, as well as human rights standards.
Yes. Can I just stop you there? You then continue on to refer to what you call the rapid migration to digital as services and activities moved online. You've touched on that. Could you go to paragraph 40? Because obviously there is a balance in relation to the use of digital services. Obviously it can be a boon to some people and a wonder. To others it can be confusing and off-putting.
Yes.
And I think that's reflected in what you say at 40. Could you just read that, please?
Yes. So regarding digital, this has been a welcome development for those who can access internet services easily and confidently. However, we know that access and use of internet services remains uneven. For example, only 43% of people aged over 75 and 71% of adults with some form of limiting long-term condition use the internet. Research has shown that disabled people are less likely to use the internet or to have internet access at home than non-disabled people. And I think one of the things that really came out, during the engagement that we've undertaken and subsequently through our digital health and social care programme, and we really kind of campaigned on this with Scottish Government as well around their digital health and social care strategy, that rather than a digital first approach, it needs to be digital choice. There will be occasions where people prefer a face-to-face interaction over digital. That might be to do with the circumstances of their health. It might be to do with situations within their wider life. We heard from people who were saying, during the pandemic they had no private space to, for which a health appointment could be accessed digitally. There were no safe spaces for them to have those conversations with healthcare professionals. To others who were saying that, they just didn't feel, particularly around mental health. Interestingly, I think there has been some real successes around the digital mental health programmes that Scottish Government are taking forward. But during our engagement, there was a really consistent theme from people that they felt that digital mental health care was not suitable for many, that they felt that they really would have preferred face-to-face mental health support during that period.
And in paragraph 41, you talk about the 5 human rights principles for digital health and social care. And could you just tell us what those are? You set them out in paragraph 42. Yes,
so the Alliance, working with Scottish Care and Vox, which is Voices of Experience, it's a member in an organisation that's led by people with experience of mental health problems. We undertook some engagement around what principles exemplified a human rights-based approach with regards to digital health and social care. So the 5 principles which emerged from the engagement that we undertook with people were that people needed to be at the centre of developments, that it was about digital where it is best suited, digital as a choice, it's about digital inclusion, not just widening access, and also around access and control of digital data.
Yeah. And I think you, well, could I just ask you, the second of those points, digital when it is best suited, that could be obviously a difficult decision to make. Who would you see as making that decision? Who would be the arbiter, as it were, as to whether or not digital was best suited?
I think from our point of view, people have to be involved in decisions about their access to health and social care. That does not need to be without dialogue taking place. I think, as I was saying before, people are often extremely, reasonable and understanding about different circumstances. But what we witnessed during the pandemic was that there was variation in access, but not because people were being involved in those decisions. These decisions were taken, behind the scenes by by government, by health boards, by services themselves. So I think for us to ensure that people's rights aren't breached, there has to be some involvement with people. We have to understand the circumstances that might lead them to say that digital is not best suited for them in that situation.
And I think you mentioned it in an earlier context, that would that involve, as it were, shelving the idea that there should be a blanket provision on this?
I think we saw too many blanket approaches during the pandemic, and for us, that was one of the major concerns we had, was that when decisions were taken, they were not taken understanding that there will be different impacts of those decisions. And for the people that we were representing and working on behalf of, many of those individuals and groups were disproportionately impacted by those, whether it was around access or the acceptability of the information or the services that were provided. And that led to some really severe outcomes for people.
Mm-hmm. You go on to talk about digital inequalities, and I don't want to simplify this, because I think obviously it's a very complex and nuanced issue. This is paragraph 44 of your statement. I suppose some of the inequalities involve, for example, an ability to comprehend and use digital technology. And then another inequality would be the ability to afford it. Are these two of the principal concerns you have?
Yeah, so definitely the affordability of the hardware was a concern, and in addition to that, the affordability of the data, the connection that people needed in order to be able to get online. So you needed to have the hardware, you needed to have the data and the connections to be able to get online. Issues around confidence, understanding, the skills in order to be able to know what's available in terms of the tools, the services, and how to access them. The other aspect is around the design, the inclusive design of services. So, you referred previously to some of the experiences people with sensory impairments encountered, where some of the only methods for them to get access to health services did not take into account their communication needs, whether it was, for some individuals accessing GP services, they were having to go through telephone lines, maybe they were hard of hearing or they were deaf, for people accessing, virtual consultations, if they didn't work with their screen readers, again, they can't navigate to get online. So inclusive design is another important factor. And I would say it's an example where there was some good practice. The Connecting Scotland programme was really well received, and the way in which it was implemented worked well. Working with community groups and organisations to utilise their networks of people they were working with and supporting to help them access devices, support and connectivity. But one of the things that so we continue to deliver some work around helping people identify what digital tools and services that are available to them. There's a huge amount of work we still need to do to develop people's understanding of what's available, their confidence in using it. We really need, if we're going to make sure that digital choice is a choice people can make, we need to make sure that we're supporting them and we're building that capability, as well as with the workforce. That there's often quite a bit of nervousness amongst the workforce as well about how to engage with people through digital means as well. So I would say there's still quite a lot of work to do there.
In paragraph 46, you, I think, summarise your position, and I think we've already perhaps looked at this. And if I can just pick up just a couple of points there. You say digital is supported by you, but not as the default position. And I think you also go on to say that there should not be a one-size-fits-all solution to this. Is that essentially encapsulating how you're approaching this issue?
Yes, yeah, absolutely.
Okay, paragraph 47, you talk about DNR, and this is again a subject that the inquiry is specifically tasked at looking at, and I think you go on to talk about it later in your statement, but perhaps we could just get the context of what you're saying. Perhaps just read through paragraph 47 for us, please.
Yes. At the outset of the pandemic, the Alliance received concerning reports from our members highlighting that some population groups in Scotland were receiving unsolicited requests by some GP practices to sign Do Not Attempt Cardiopulmonary Resuscitation forms, or DNA CPR forms. Our members, Age Scotland and National Autistic Society Scotland, are among those who have raised the issue. While DNA CPR forms have an important role in anticipatory care planning, decision-making should be based on an open discussion with individuals and their families and firmly cemented in human rights standards. Blanket approaches should never be taken. The inappropriate use of DNA CPR forms during the pandemic has caused distress for many people and their families. The longer-term impact of the increased number of DNA CPR forms completed, their improper use and the impact on individuals and families must be addressed by the inquiry, as well as recommendations on how to prevent a situation like this happening again in future.
Just to take up some of the points you make there, and I know we look at it later in your statement, perhaps in a little more detail, but I think it's useful in that context. One of the things that we've heard and will continue to hear, I think, in this inquiry is the need for DNR notices and forms to be accompanied by proper and compassionate discussion about them. Is that something you favour?
Absolutely, and I think, we recognise, as an organisation who, we've been working around, this and similar issues for many a year now, and people understand that anticipatory care planning and planning for end of life care, is something which is a real matter people will engage with and need to engage with. The way in which it was handled during the pandemic with calls, I mean, there was one mum who shared an experience where she received this unsolicited request, and it was about her child, and she was told that this form was going to be applied to her son, and there would also be no hospital transport in the event that he needed support to save his life. And it was delivered to her pretty much as a cold call, extremely distressing and traumatising for her, and has left her really questioning the support that is available for her and her son, now and in the future. We call in, and I believe we'll cover this in more detail, but consistently what we hear from people is that they are looking for a greater sense of person-centredness in the care and support that they receive, navigating the healthcare system, particularly when their circumstances, will require them to have, repeat or frequent engagements with the healthcare system. So it's not that people want to, overlook these issues, or that they're putting their heads in the sand or anything, but that they want to have a meaningful conversation with a healthcare professional about these issues ahead of time, not at a point in crisis, and not in a way which is about protecting the service, not protecting their life and their rights.
I suppose, given using the example you gave, I suppose there is a necessity to discuss those matters, but there is a way about how you should do that.
Yes.
And that probably was not the way to do it.
Yes, absolutely. And I would add, there is guidance around anticipatory care planning. There has been a programme of work which Healthcare Improvement Scotland has been taken forward. Gosh, a number of years ago we were involved, so I would say several years, maybe dating back even to kind of 2016 or around that time, to try and increase the use of anticipatory care planning across Scotland. So this was something which, again, need not have been an issue during the pandemic if it had been implemented in the way in which the guidance said, that this is about having early conversations with people, not just about their end-of-life care wishes, but about what's important to them, as they progress through life, as their health maybe deteriorates, as it's not just about as things get towards the end, but really about planning for the future.
Well, perhaps we could take a break briefly at that point. Thank you.
We'll come back at about 25 past 10. Sorry, I beg your pardon, 11. Thank you. Yes, Mr. Gill.
Thank you. Ms. Redmond, we've been talking about DNR notices before the break, and can I take you on to paragraph 48 of your statement and following, because here you return to the question of long COVID. And again, to a certain extent, these are some of the points that we've already touched on when we looked at it earlier today. Just one or two points I'd like to take from you in relation to long COVID. First of all, I take it from what you are saying to the inquiry that this is a condition about which you and your members reflect to you that is quite appreciable within the population now. And I think you've given a figure in paragraph 48 that the Office of the ONS estimates that 2.1 million people in the UK are living with the condition. And I assume that this is just a simple reflection of the population of Scotland, that if that's the sort of figure in the UK-wide, then we would be talking about 187,000 people in Scotland.
Yes.
Do you think that's a realistic figure?
I think the trouble is that we don't know for definite, and I think you know it is something which does need to be, the issue of data. You know, I think is possibly something that we might talk about a bit as well. But I think the issue of recording and capturing data in a way that helps us to understand the prevalence of different conditions that people are living with. But I think if we're looking at that figure across the UK, then that would be, it would be accurate for us to assume that there is an equivalent proportion of that population living in Scotland with this condition.
Yeah. And you've given us a number of quotes from respondents to your organisations. And some of these are, I think, perhaps sum up the point that you're wanting to get across about long COVID. In paragraph 49, the respondent said that long COVID is life-changing. Sometimes it feels like we are invisible. Can you? I'm asking you obviously to comment on somebody else's comment, but do you understand that?
Yes, I think one of the things that that struck me from listening to people's experiences of living with long COVID was that they were overwhelmed at the fact that their experiences initially were not believed. They received feedback that, well, they couldn't still be living with symptoms. They'd had COVID, months ago. How could they still be describing these symptoms? There was no place to go to get support, to get information. They were having to do all this research by themselves. And that is, why we have seen the numbers of people who are connecting with peer support groups, online groups, etc., so that they can share the experiences of the research and the support that they have found. I would also say it's not an experience which is unique to long COVID. I think working with the Alliance for the years that I have, that feeling of being invisible is described by people living with other conditions as well. Particularly conditions which are perhaps harder to diagnose. There might not be one recognised, test or procedure to diagnose a condition. Such as people living with ME, chronic fatigue syndrome. People living with endometriosis. Other conditions that, those experiences. And I think that's coupled with what we were talking about by, dominant messages in the media and publicly, that there was a perception, not by everyone, in the kind of public narrative, but a feeling as though this was a made-up condition. This was not a real condition, and I think that has just compounded those experiences for people feeling as though, their lived experience of this has just been completely overlooked.
I suppose in that context, what is said in paragraph 50, the quote there, is along with the fatigue, the other biggest thing is attitudes.
Yes.
The more education there is, education is so important, and with that, maybe it would be a bit more recognised. And I suppose also certain comments that have been made. So Boris Johnson's bollocks probably didn't help.
No, absolutely.
Yep. 51, there's as you put it, an anthology of opinions about, perhaps you would just read that quote, please.
Yes, absolutely. It is disappointing that despite the information we now have on long COVID, people are still struggling to have their voices heard. I've lost count of the number of people who've told me they were dismissed by their GP and other healthcare professionals, being told that they were suffering from anxiety and that they should get out and exercise more. People in employment are also struggling with their employers, with many being forced to go back to work when they're not ready or facing disciplinary action. Dealings with the Department for Work and Pensions have also added to the pressure people are already facing, particularly with PIP, which is Personal Independence Payment applications, with people giving up on claiming benefits they're entitled to because the claims processes are far too exhausting for them.
Can I just bring this section on long COVID to a conclusion at paragraph 54 of your statement? This is, I think you're looking at the support that is available to individuals with long COVID. And you conclude by saying that it is clear that these experiences are inconsistent and varied across Scotland, with participants acknowledging their own positive experiences as unusual. That's the import that you've taken from this.
Yes. And I wouldn't say that, I mean, I definitely think progress is being made and continues to be made, but I don't think we have a comprehensive package of support for people. And across Scotland, I think there's still a lot of variability.
Okay. Paragraph 55 and following, you touch on shielding and shielding measures. And you say that this, your members shared how shielding measures had a significant impact on certain population groups who were often the most marginalised and excluded people in society. And you say these included disabled people with long-term conditions, unpaid carers, minority ethnic people and older people. That was the information you were getting back from your members.
Yeah.
And also you mentioned the concerns that were raised about the consequences of shielding. And these are probably the ones that we've come across quite often in our discussions. Social isolation, inadequate access to food, health issues going unnoticed or undetected. Again, that's something that was being reported back to you.
Yes.
And you go on to talk about confusing and contradictory guidance. Can you give us some context for that comment, please?
So I think initially what people found confusing was whether or not they were on the shielding list to begin with. I think there was, there was a situation where down to what data, coming back to what data actually was held nationally on people across across society through the health service. There were some people who were identified as on the shielding list and received a letter accordingly. There were others who were able to be added on because of they were liaising with local GPs, other healthcare professionals. We also, through our links worker service, were aware that through relationships that links workers had with different members of their practice population, they were able to advocate for the inclusion of members onto this list. So there were some people who thought they should have been and weren't added on. They might also be in contact with someone else whose circumstances were quite similar, but they themselves were in a different situation to someone else. And of course, being identified on this list meant that they had access to, documentation which they could use to share with their employer, with others, to identify that they were shielding. It gave them, they were able to access local support as well, to counter some of those issues around isolation and access to, essentials. I think as well the way in which the process was managed as the pandemic progressed and the shielding list transitioned into a higher risk list, and some of the communications then that subsequently came out to people felt confusing to them, particularly what they should be doing, could be doing, shouldn't be doing, and the point we're making here was that this was exacerbated by the fact that the way in which restrictions were eased and continued to be implemented differed, whether you were living in Scotland, which part of Scotland you were living in when restrictions were locally applied, and if you were living in different parts of the UK. So trying to navigate that, the complexity of it was perhaps inevitable, but, being able to, make the right decisions based on your circumstances was critical for people. So they needed to have access to that information to be able to know what they should be doing, could be doing. Mm-hmm.
You say at paragraph 57 that many people feel that they are being left to fend for themselves. Is that a reflection, really, of what you've been saying, that if somebody has been shielding, felt that there was a necessity for them to be shielding, yes, and then restrictions are eased, there might be an understandable reluctance to go back to what might appear to be a normality? Yes,
absolutely. And I think as well that this relates as well to whether or not those people are able to access boosters, whether they're able to access the kinds of treatments that can help prevent, for people who couldn't, who wouldn't benefit from vaccination, if they're able to access a treatment that would be supportive of them. I think there's a whole range of aspects to this which is making it very difficult for people to continue living their life when there are still risks to their health from COVID.
Yes. Right, could we move on to unpaid carers, please, at paragraph 58 and following, and again touched on this a little. And I think you make reference to the Alliance as being part of the Carers Parliament in November of last year, and looking at the ongoing impact of COVID for unpaid carers. Could you read on from paragraph 59, please?
Inclusive of 59?
Inclusive of, yes.
So participants shared experiences of miscommunication, lack of clarity in information provision, and confusion about risks. For example, information about who should be on the shielding list was contradictory or lacking. One person's condition meant that while they were not formally on the shielding list, they were advised by specialist healthcare professionals to shield. With measures taken to control the virus being reduced, participants shared that it now feels like public perception and public health messaging has shifted to the COVID-19 pandemic being over. Fewer people are wearing masks, yet people at high risk of COVID-19 infection and their carers are continuing to shield. As a result, many carers and those they support feel left behind. Carers also described anxiety around their own health conditions, maintaining their caring responsibilities, fear of contracting COVID-19, but also managing feelings of anxiety and isolation. As summarised by one participant, it feels unsafe to leave the house because the risk of infection is still very real. Social work helped in the beginning of COVID-19, but we felt left in the unknown.
Yes. Thank you. To a certain extent, what follows in paragraph 61 and following does follow on to a certain extent from unpaid carers. And again, can I trouble you just to read 61, inclusive and following?
Mm-hmm. Absolutely. This was a really strong theme from the engagement we've had with members. So we heard from our members that there was reduced and disrupted access to healthcare services across the board, where the prioritisation of COVID-19 has had an impact on people with non-COVID-19 needs. Whilst people have shared their understanding about the unprecedented demand that COVID-19 placed on health services, the impact of the lack of access has been considerable and has led to a deterioration of people's physical and mental health. Individuals told the Alliance that they experienced a number of disruptions when trying to access healthcare services. For example, health clinics had been paused, outpatient appointments and elective surgeries cancelled, face-to-face appointments reduced or cancelled, and waiting times increased.
Yes. And I think you then give a quote.
Yeah. So this is an example of a quote that was, reflective of many of the responses and conversations we've had with people. They felt like that they're inaccessible. So this is about healthcare services. They felt like they're inaccessible unless you have COVID. I received messages from GPs advising not to visit the surgery at all, but never received a message saying it was now safe to do so. Yes. So people really described to us, not knowing what was available, how they should be accessing it, what was an essential service. And I think, some gave examples where, essential services such as, supermarkets and, other services which were, of course, deemed as essential. But for many people, those other healthcare services were equally essential for them to maintain their health at a level, and those weren't, it wasn't either communicated to them whether they were accessible or they just weren't.
You mentioned then in paragraph 63 audiology services. Mm-hmm. Just tell us a little about that.
Yeah, so this is an example, and this was a separate piece of engagement that was carried out. And I think one of the things I would say is that, and I've referred to it around, where people typically discuss and describe sometimes their frustration at the lack of person-centredness, the continuity of care, the coordination of care, to what extent they're actually involved in decisions about their care and treatment. This was not unique to the pandemic, but we carried out some engagement to inform an independent review of national audiology services across Scotland. So during this, people told us about long waits that they'd received, that they'd experienced during the pandemics, and this was one example of a quote that someone had shared with us. They'd had to wait 12 months with profound hearing loss and no hearing aids over COVID, which meant I couldn't understand lectures or go to work.
And I think there's also a reference to professionals discussing the backlog of cases.
Yes.
Paragraph 65, I think, is a general observation, and again, I think it would be useful if you read that.
Yeah. So in our briefing learning from changes to social care during the COVID-19 pandemic, we wrote to 32 local authorities and received many responses which aided in our learning around good practice and learning that emerged from the pandemic, as well as areas that could be revised. Local authorities and health and social care partnerships spoke about working collectively with external partners and social care providers at local level to deliver services. One example of this was an online weekly provider forum to ensure the efficacy of PPE supply and delivery to social care providers, to deal with any queries, to monitor emerging areas of concern and ensure that there was continuity of support.
Is that something that's ongoing?
Well, this was one of the things that that came out strongly during the pandemic. Was one of the real success stories was at a local level, the collaboration and partnership working which did take place to respond, almost in contrast to perhaps what had existed before. I'm not sure whether this example still operates, but we have heard, you know, a lot of feedback from members working in the third sector that, and also from health and social care partnerships, a concern and a lament that collaboration, that spirit of partnership working has receded. And actually, I think because of the financial crisis, it's almost been replaced by the opposite.
Yeah. Okay. Probably the subject of money has to be addressed, and to a certain extent you do that in, as you go on in your statement and talk about funding. You say in paragraph 66 that third sector organisations adapted and responded flexibly to the COVID-19 pandemic to ensure that people in their communities were supported and not left isolated. However, some local authorities and HSCPs also refers to the negative impact of COVID has had on commissioning arrangements with third sector organisations. Can you explain what that is?
The commissioning arrangements?
Yes.
So commissioning refers to a whole a cycle of planning and investment processes whereby you know, the needs of a particular population will be looked at. There will be a look at what you know, what does the market look like? What in terms of providers to respond to some of those needs? What kinds of interventions need to take place to encourage more provision of services, and can also then involve procurement. So it's a whole kind of cycle of activities, but is often involves ultimately an arrangement where a tendering process is undertaken. So a local authority or a health and social care partnership will identify they need a provider of a particular range of services. They will set out a brief, and then they will invite proposals from different providers to respond to that.
What was the negative impact that you're talking about?
So I think what many areas experienced was just the challenge with capacity. There was some problems in just being able to go through commissioning processes because they were having staff were being relocated. There were financial pressures as well on areas because they were having to provide for different responses than what they had been used to be doing. There was also an impact where organisations were not seen as essential, so they were furloughing staff because there wasn't, this was not seen as a kind of part of the essential services that were available, and also the impact on many third sector organisations financially was also really challenging. Some of their provision will have been supplemented through fundraising, through charity shop, sales, through volunteering. That was really, really difficult to manage during the pandemic.
And I think you reflect that in the bottom of paragraph 66.
Yeah. So, vital services were not being delivered in some areas. There was impacts on social care packages and then on people's well-being.
Paragraph 67, you say the third sector continues to be undervalued and under-resourced. I think I probably understand, add another under into it, under-resourced, undervalued. Can you indicate why you say that? And can you indicate also who you feel undervalues the third sector?
Yeah, I mean, I think, one of the things, and it wasn't just, as a third sector intermediary, we would of course be, celebrating and pointing to the good work happening in the third sector during the pandemic, but we weren't alone. Scottish Government, Healthcare Improvement Scotland, also provided reports and research which documented the very agile, flexible and at pace response that the sector provided to support people, often in really significant ways as well. That, I think the other thing that we saw during the pandemic was that funding was provided without the kinds of strings attached that you typically see through either grant funding or through, contracts and service level agreements, whereby, organisations were trusted to respond to the needs they were encountering locally. Organisations really appreciated that. They adapted quickly to provide for the kinds of basic needs that they were encountering. When we refer to that being almost the exception in terms of the value placed on the sector, what we see and have seen for many a year is that the contribution that the third sector makes in terms of community health provision and as a provider of a lot of social care support and services, we tend to not be included as a matter of course in decision-making bodies, in governance and oversight boards and bodies as an equal partner. The kinds of agreements, we've recently heard of one local authority area that is going out to re-tender for a service at a lower value than it currently provides that service for, despite the fact that costs of delivering services for all of us have gone up. We are we're not referenced. Typically, there was the Health and Social Care Workforce Strategy by Scottish Government. The third sector workforce does not feature within that. Where it tends to be recognised as a contributor to our health and social care system, by and large, that tends to be within the social care sphere. But there's a huge number of organisations that deliver a whole range of support for people's health and well-being, ranging from peer support groups and provision to really specialist support. There's organisations that provide rehabilitation and habilitation support for people with sensory impairments. There is, really specialist support for people living with, neurological conditions, befriending support. The response that was provided during the pandemic relied on that ecosystem within the third sector. And I would be really concerned that the way in which the sector is treated and the resourcing that goes into it, the lack of long-term funding, the lack of planning, and real understanding about there's waste in the sector caused by the way in which the sector is treated, that provision might not exist if we don't make sure that we're looking after it.
You make a recommendation in paragraph 68, which I think you then expand on in 69, that funding, I assume this is general funding for the third sector, should be provided for longer time periods, and founders and commissioners should support a flexible approach, and then you refer to the fair funding principle set out for the Scottish Council for Voluntary Organisations, that funding should be multi-year, flexible, sustainable and accessible. And you say that if the third sector is properly funded in a way that is set out under these principles, then it will be better prepared for a future pandemic. Mm-hmm. That's your view?
Yes, yeah, very much so.
Really, I suppose as a generality, if one goes down to paragraph 72 in your statement, you mention there that there have been and were positive changes in the course of the pandemic, but that they are now being reversed without proper consultation. Can you give an example of that, if possible? And can you, well, just comment on that as a process?
Yes. So examples that were given both by representatives from health and social care partnerships, as well as people working in the third sector, was that there was a spirit of collaboration which was enabled because we were all united with a common goal. And organisations, I remember one organisation saying, you know, the Health and Social Care Partnership is actually coming to me to say, how can we work together on making sure that, you know, we're reaching people, you know, across society, you know, can we work together on these matters? So that was extremely welcome, you know, from all sides. You know, as restrictions began to ease and we began to kind of plan more for recovery, there was a concern at the time that we might not be able to learn those lessons quickly enough and implement them so that they become more business as usual. So there was direction set nationally, which, you know, allowed for perhaps some of the procedures that would typically be in place to be loosened, so that, you know, it was more about you know, responding to those kind of emergency needs. That concern, I think, is definitely being evidenced by you know, work that's happening locally. You know, I was referring to one, you know, an organisation who was concerned about the arrangements for the recommissioning of a service for you know, particular service provision around social care, and, you know, they were really concerned that they were being expected to tender for that service at a lower cost, which would not allow them to reflect the additional costs that have just been incurred because, you know, energy's higher, rents are higher, but also actually pay their staff you know, an increase because, you know, their costs will have also increased. You know, personally as an organisation, we're seeing that as well. You know, one of the services we deliver in Glasgow, you know, an example of a very person-centred support, the Community Links Worker Service, and, you know, because of the funding pressures on national government and locally, you know, that service provision is being cut. It's not just about the cuts, it's also about how those decisions are taken. So, you know, we were not consulted, we were not involved in the decisions around that. The staff weren't involved in those. The people accessing those services were not consulted. You know, that goes against you know, guidance. It goes against what you would witness if it was a public sector employer. You know, there are different standards. You know, depending on whether you work for the public sector or the third sector, an independent sector in health and social care. All
right. You'll appreciate, Ms. Redmond, that probably some of these things are beyond the remit of this inquiry, and probably certainly beyond my wit. But we do know that the Scottish Government, in its opening statement to this inquiry, said that it would be listening to everything that is said, and obviously what you've said, I'm sure, will be heard by the government in that context. Paragraph 74, you deal with really about staffing, well, perhaps you can just summarise what you're saying there.
So the pandemic led to significant changes in staff structures and the way in which services were delivered. And our research found that local authorities and health and social care partnerships adopted different ways of working. There were some areas where, teams were working exclusively from home during the height of the pandemic. Others were operating a more hybrid approach with rotational staff bubbles. There were examples of wellbeing hubs set up, including utilising, local public library spaces, which would allow staff working in maybe care at home services, where they're going out and visiting people's homes, to be able to come to a hub, a place where they could, meet others, delivering similar services, and have a break, have somewhere to come to, and just reflect on the difficulties that they were experiencing delivering those services. So there were definitely, some really positive examples where the flexible working. There was also examples where there was delegated decision-making down to social workers at a more frontline level, so that they could make a decision about a person's, an assessment of their care needs, and actually make sure that that provision was put in place at a much quicker, much more quickly and proactively than would be usually when a decision has to be taken to a kind of decision-making board to approve that.
Right. And I think what you say at paragraph 77 is that you recommend that there should be a review of COVID-19 working practices undertaken to ensure the areas which worked well can continue to benefit people accessing support and health and social care. Do you know if that is going on?
Not to my knowledge.
Okay. Right. We're coming to the end of your statement, Ms. Redmond, and what you conclude with is a series of bullet points in which the Alliance, through you, make certain recommendations. A word that we're going to come across, both with you and with the Women's Rights Organisation, is intersectional. Can you just explain that to me?
Yes. So by that we mean, having an understanding that, people's identities are not siloed, that, there will be an intersecting of, identities and characteristics that will mean that a person's experience in society will be impacted not just by one label, but by those intersections between a number of their identities or characteristics.
Thank you.
Mr. Gale, would I also just be able, before we look at the recommendations, just to cover some of the experiences around social care?
Yes, certainly.
Yes,
if you'd like to.
Would that be okay?
Yes, please do.
Reflecting on what we were talking about around flexible working and some of the spirit of collaboration around with local authorities and health and social care partnerships. Another aspect which people shared with us, quite substantially, was their experiences of their social care packages and accessing provision around social care during the pandemic. We heard from people that without much notice or any notice that their social care packages would be stopped, that was communicated without an explanation, you know, really, or without any alternatives about what else would be put in place, and again put quite a lot of pressure then on family members and people providing unpaid care. There were, you know, there was guidance which allowed local authorities and health and social care partnerships to lessen the requirements around an assessment or the extent of the assessment that had to take place. The guidance was that was to expedite the process and make sure that people were able to access the care they needed without lengthy delays. Yet, in practice, sometimes what that led to was, you know, people, you know, those assessments not being communicated to people in a way that provided them with the information about what they were going to be able to access, and also seemed to then lead to a tightening of the eligibility criteria, so that they had to meet a higher threshold in order to access social care. There were also some examples that some local authorities had suspended their complaints processes, which again is a really important process that allows people's rights to be protected if there were concerns that they had about the provision that they were receiving, and that was raised by ourselves and the Scottish Human Rights Consortium, that you know, this was not acceptable. There were some examples, so I would, you know, and I spoke to some of those beforehand, where, you know, there were some positives around, you know, greater flexibility for social workers making decisions. There were also some opportunities where people were able to use their personal budgets more flexibly to help them meet some of the aspects of their daily living needs and circumstances, maybe to employ a family member as a personal assistant, which again allowed them to have some choice and control during that time. I think that was one of the things that we kind of advocated for strongly, was that the experiences around social care were given, you know, due consideration during the inquiry process, you know, substantially because the way in which decisions were made were really difficult to track and to monitor for organisations and for people accessing social care. And, you know, for many people, you know, social care is about enabling them to you know, live an independent life and be able to participate. You know, it's a hugely critical, you know, provision of support and services for people. So, you know, those experiences are really important that we hear about as well.
Just taking one point that you've mentioned there, and I think you mentioned this again earlier. If I can put it this way, and I'm rather loath to ask this, because it is probably not a question that can be answered in the generality, but has to be done in the specifics. But so far as the input that your organisation has had, was I suppose the greater autonomy that was given to certain social workers, was that welcomed?
Yes, and I think, you know, as you say, I don't feel I have the authority to be able to say in all circumstances, but I think it was definitely welcome. I think it's, you know, some local authority areas are continuing to develop their approach to allowing greater autonomy for frontline workers, and there are some really positive examples of it elsewhere in the UK as well. One of the concerns and the frustrations that people often share with us when accessing social care is that the decision-making process, despite, you know, really bold and robust legislation which talks about choice control, and the participation of people accessing social care in decisions about their social care provision, that after an assessment is carried out, the decision is taken away and it's made in a closed room by others. So I definitely think, by and large, that was something which was welcome.
Okay, thank you. Can we go back to your recommendations at 78? I'd like you just to read these through.
Yes.
If you would, Ms. Redmond, and at the end of it, we'll perhaps discuss one or two of them.
Certainly. So the Alliance also makes the following recommendations for future pandemic readiness. Adopt an inclusive and intersectional rights-based approach to policy and decision-making. It is imperative that people's rights are protected, respected and fulfilled as the Scottish Government continues to respond to the COVID-19 pandemic and future pandemics. Decision-making should be underpinned by an inclusive, intersectional, rights-based approach which prioritises the rights of those most at risk. We recommend to listen meaningfully to disabled people, people living with long-term conditions and unpaid carers to inform and co-produce policy decisions. The Scottish Government must listen meaningfully to people's experiences of COVID-19, including what they are continuing to experience. They should be accompanied by appropriate action co-produced with people with lived experience. Also, to ensure clear, consistent and compassionate communication, recognising that public health information is integral to a person's right to health. Communication must be clear, consistent and recognise the disproportionate impact of the COVID-19 pandemic and the impact that it has had and continues to have on different population groups, including people living with long-term conditions, disabled people and unpaid carers. It's important that the risks of COVID-19 infection or future viral pandemics are made clear to the general public. We recommend to produce a ventilation strategy for public spaces to enable people at high risk and carers to access public spaces. A robust ventilation strategy is needed for public areas, and a clear and accessible ventilation strategy would support people to know that they are safe to access public spaces with reduced fear and anxiety. We recommend to increase eligibility for and access to antiviral treatment. Investment, funding and research is needed to increase eligibility for antiviral treatment, particularly for those with low immunity. And to adopt a trauma-informed approach to COVID-19 and future pandemic decision-making. Future decision-making must recognise the magnitude of loss, bereavement and trauma that people have experienced since the beginning of the pandemic. Decision-making needs to be considerate of the human rights standards such as non-retrogression. This means that retrogressive measures should be prohibited, except if all of the strict rules governing these choices have been met. This would ensure that policies adopted that decrease anyone's enjoyment of their right must be temporary, necessary and proportionate, not discriminatory and mitigate inequalities. Ensure the protection of minimum core content of rights and have considered all other options, including financial alternatives. This provides a robust framework for protecting rights within decision-making in any future pandemic. We recommend systemic change for social care. Participants highlighted the need for longer-term solutions to respond to systemic issues in the social care sector, such as the removal of social care charges. It's important that such changes take place without delay, rather than waiting until the implementation of the National Care Service in Scotland.
Yeah. Having said that, I'd come back to one or two of those. I'm not entirely sure that I need to, because you've set them out, unless you particularly want to. You've set them out very fully. If there is, and I say this to all witnesses, if there is something that you would like to emphasise particularly, please do so. This is an opportunity for you to do that. I'd also repeat what I've said to other witnesses, that after you've left this room and there's something that occurs to you, please get in touch with the inquiry, and that information will be added to the body of your evidence. So please don't think that this is necessarily the end of the process so far as your input is. But if there's anything you would like to highlight or expand on, please do so. I
think with regards to the first point about embedding human rights standards and principles into decision making. I know that the World Health Organization emphasised people's participation within a pandemic's preparedness and decision making, and whilst I think we and our members can understand that decisions, particularly at the outset, had to be made at pace. There was too many occasions where blanket approaches were applied and there were not opportunities taken to involve people to understand the implications on their health and well-being. Human rights standards don't tell you what to do in a particular situation, but they can provide you with parameters and, really welcome standards to allow the tensions between, rights and risks to be surfaced and to be thought through. So, we're not making that recommendation as if it would be, it would provide all the answers, but it provides a really important framework, people's rights, even and perhaps especially in pandemics, need to be protected and respected. I think one of the other things when we're saying about people whose rights are most at risk, those people most disproportionately impacted, that was not unknown. It was not not a surprise, but it wasn't to be unexpected. When we look at the evidence about those experiencing the greatest impact of health inequalities in Scotland, these are the same groups in society who were most disproportionately impacted by the pandemic and the response taken to it. If we are to be better prepared in the future, that means addressing some of the ongoing population health crises that face us around, people's access to the building blocks of health. It's vital that we address, some of those risks that people continue to face. And I would also add that, I've referred to it at previous times during this statement about the desire many people that we represent have for, greater person-centred care and planning when they are navigating the health and social care system, and particularly, around healthcare. There's not enough examples of person-centred planning, continuity of care, the importance of recording that and understanding, tracking the data around, people who access our healthcare. It should not have taken the efforts it took to identify those people who needed additional support when restrictions were being imposed. And lastly, I would just reiterate the points I was making before about, the third sector. I strongly is a really valued from people that we spoke to. They often described the access they were still able to have to support through the third sector as some of the positive experiences that they described when they were talking about their health and well-being during the pandemic. It's a vital contributor to our health and social care system, and it's not treated as such in the funding decisions that are made and in the strategic decisions which are being made nationally and locally. And I feel that our response to public health emergencies is enhanced by a strong third sector, and I think that's something that we really need to be considerate of when we're thinking about the lessons we need to learn.
Ms. Redmond, those are all the matters that I want to discuss with you. Thank you very much from my perspective for obviously the care that you put into your statement and the care that you've given to your evidence today. We're very grateful to you.
Thank you, Mr. Gill.
Yes, thank you, Ms. Redmond. Very good.
Thank you, my
And I
lord.
think that's all we have for today.
It is, my lord, yes.
Thank you very much. Tomorrow morning at 10 o'clock.